Next, we have Dr. Reshmi S., who is a consultant refractive and phacosurgeon, Eye Foundation Hospital, Kozhikode. She will be talking on hypopyon handling.
Good afternoon, all of you. I will be talking about hypopyon handling, the differentials and strategies for the effective management. So, we know that hypopyon, this corresponds to the sedimentation of WBCs within the anterior chamber, and it signifies severe intraocular inflammation. The basic pathophysiology is the leakage of proteins and WBC from the inflamed blood vessels. The causes can be many. Non-infectious include uveitis like HLA-B27 and Behçet's, iatrogenic conditions, medical agents like rifabutin, surgical causes, chemical mechanical injuries. Infectious conditions include exogenous and endogenous infection, and sometimes neoplasms like leukemia, lymphoma, melanoma, etc. So, for the diagnosis and management, we need a careful history taking followed by a meticulous systemic and ocular examination. So, history taking, we are all well aware of. About the systemic history, ask about skin, hair, nail changes, oral or genital ulcer, urethral discharge, fever, neuropathy, etc. Coming to the ocular examination, there is an elaborate naming and meshing system for the classification of hypopyon and pseudohypopyon. A variety of parameters are mentioned in this. I will go through the important ones only. So basically in this talk, we will be differentiating between hypopyon and pseudohypopyon. Based on the formation, hypopyon can be spontaneous as in HLA-B27 or provoked as in the case of a trauma. Pseudohypopyon is always spontaneous. Based on visibility, it can be classified as macro, micro or angle. The first image shows a macrohypopyon that can be seen with the external eye. Second image shows a microhypopyon that can be seen on slit lamp examination, and the last image shows the hypopyon that can be seen in the gonioscopy. Based upon the orientation, it can be horizontal, layered at 6 o'clock as in HLA-B27, or it can be vertical or oblique as in a bedridden patient. Pseudohypopyon can also be horizontal or vertical. Based on shape and position, it can be board-shaped in fungal end-off, convex in microbial keratitis, pyramidal in fungal keratitis, ring-shaped in meningococcal end-off, and inverse in infectious scleritis. Pseudohypopyon can be lumpy wavy type in tumors and inverse type in siliconoid patients. The first image shows the lumpy wavy type in retinoblastoma. It's a pseudohypopyon. Second is yellow hypopyon in a contact lens-induced ulcer. Third one is a triangular hypopyon in microbial keratitis. Fourth one is a panophthalmitis patient. And the lower image shows a board-shaped hypopyon in fungal end-off. And the last one shows inverse hypopyon in infectious scleritis. Based on the color, hypopyon is commonly white in color as in HLA-B27. It can be pink without hyphema in serratia. Candy cane, that is a mixture of hypopyon and hyphema in viral infections. Dark pigmented with melanin hypopyon is seen in listeria and serratia-induced end-off. Pseudohypopyon is usually dirty white in color as in mets and primary tumors. Crystalline white is seen in post-IVTA patient. Yellow colored with cholesterol crystals are seen in cholesterosis bulbae. Brown color with hemolysis is seen in Gaussian glaucoma. Blood tinged with tumor cells seen in intraocular lymphoma. And black with melanoma cells are seen in primary and metastasis. The first image shows a brown hypopyon. The second one shows crystalline white in IVTA patient. The third one is a blood tinged hypopyon. The lower images show black hypopyon and yellow hypopyon. Based on mobility, hypopyon can be shifting within minutes in Behçet's disease and non-shifting in HLA-B27. Pseudohypopyon usually show shifting within seconds. This is the characteristic mobile hypopyon in Behçet's disease. In the sitting position, it is horizontal. On head tilt, the hypopyon is also tilted to one side, and on complete head tilt, it becomes vertical. Based on scleral show, it can be warm or cold hypopyon. Warm hypopyon means there is circumcorneal condition along with AC reaction, as in HLA-B27. Cold hypopyon means AC reaction without circumcorneal condition, as seen in post-IVT and tumors. The first three images show some amount of circumcorneal condition with hypopyon, that is a warm hypopyon. The lower images, it shows the right and left eye of the same patient. We can see that it's a completely white eye with hypopyon in one eye, so it's a cold hypopyon. Based on laterality, it can be unilateral alternating in HLA-B27 and non-alternating as in after IVTA patients. Bilateral, symmetrical and non-symmetrical are seen in rifabutin patients. Based on location also we can classify. It can be layered within the cornea as in keratitis. Usually it's seen in the anterior chamber. Double hypopyon can be seen both in cornea, anterior chamber and sometimes within the capsular bag. Subretinal hypopyon means inferior exudative RD with inflammation of subretinal space. This image shows a hypopyon within the anterior chamber as well as within the capsular bag with an endothelial plaque. Pseudohypopyon usually mimic hypopyon in uveitis when it is in the anterior chamber. It can be within the capsular bag in Propionibacterium. Lactocreminacea is a milky white fluid collection within the capsular bag because of the occlusion of the anterior rhexis opening. It is seen in phacoanaphylactic end-off. Pre-retinal pseudohypopyon seen in syphilitic vasculitis and intraretinal one is seen in Best dystrophy, subretinal in prolymphocytic leukemia. So the first image shows a milky white fluid collection within the capsular bag. The second image shows intraretinal pseudohypopyon in Best disease. This is the pre-retinal pseudohypopyon and the last one is the subretinal one. Based on the purulence, inflammatory hypopyon consists of exudates, proteins and necrotic debris, while suppurative hypopyon contains some amount of pus cells also. It is seen in corneal infections. Non-suppurative hypopyon is seen in herpetic infections and non-inflammatory one is seen in metastasis. Based on the onset, we know that it can be classified as acute and chronic, and based on the pathology also we are all familiar with. Based on the course, it can be transient, that disappear after treatment, seen in IVTA patients and HLA-B27. Persistent can last longer in metastasis and primary tumors. So coming to the next part, that is systemic examination of the patient. The type of inflammation, if it is acute and sudden onset, look for associated factors. If there is arthritis, back pain or GI symptoms, etc., it can be seronegative arthritis. Check HLA-B27 and X-ray sacroiliac joint. If there is associated aphthous ulcer, it can be Behçet's and go for HLA-B5. If it is post-op or trauma patient, it can be end-off and check a vitrectomy. If it is medication-induced, it can be rifabutin, and if it is idiopathic, it can be HLA-B27. On the other hand, if it is a moderate severity of pain and redness with some amount of shortness of breath and subcutaneous nodules, think about sarcoidosis, check ACE, lysozyme and chest X-ray. If there is increased IOP with some amount of central iris atrophy, it can be herpetic iritis. If there is poor response to steroids and manifestations of secondary and tertiary syphilis, check VDRL and FDA-ABS. Also, if it is a post-op patient, it can be endophthalmitis. It can be medication-induced like latanoprost. If there is history of HIV or if there is exposure to TB, etc., check for purified protein derivative, quantiferon TB gold and chest X-ray. If it is a chronic type of inflammation in a child, especially with arthritis, it can be JAA. Check ANA and ESR. If there is heterochromia, diffuse stellate capes, it can be Fuchs. And if it is post-surgical, it can be low-grade end-off also. So in some patients, we may need to go for an aqueous tap to check for the PCR and cytokine biomarkers. The indications include atypical clinical appearance, recurrent uveitis of uncertain etiology, therapy refractory cases, immunocompromised or older patients, limited fundoscopic examination. So to conclude, a careful history taking, detailed stepwise slit lamp and systemic examination can help in 70% of diagnosis in the case of a hypopyon. Detailed evaluation of sediment is indicated in some patients only. So with these points, we can identify the etiology and initiate proper treatment in a hypopyon patient. Thank you.
Thank you, Dr. Reshmi, for this wonderful talk.